I'm going to record, and we're about to start.
Great. Hi, welcome everyone. I hope you all are doing well. Thank you so much for joining today's webinar produced by Friends of Winship. Friends' mission is to build community understanding and awareness about Winship while raising funds to support our research and patient care programs. And Friends is led this year by Janet Turman. Before we get started, I'd like to review a couple housekeeping notes. This program is being recorded, and if you have any questions, please use the chat button at the bottom of your screen. Today's program is led by Dr. Kevin Kalinsky. He's the director of the Glenn Family Breast Center at Winship Cancer Institute, along with Dr. Jane Meisel, associate professor in the Department of Hematology and Medical Oncology at Emory University's School of Medicine. Now I'll turn it over to Dr. Kevin Kalinsky to get us started.
Thank you. We really appreciate everybody spending the hour with us, and it's really nice to have some time with Dr. Meisel, who will be having a bit of a back and forth. And even to get started, we really just want to reiterate that the goal of this is for this to be as interactive as possible, meaning if there are any questions that come up on any topic, that Dr. Meisel and I are happy to discuss these, and because we really do want this to be a back and forth. And like I said, we really appreciate the opportunity for you to be with us, and hopefully next year we can be in person as opposed to doing this virtually. So I only have maybe a couple of slides that we just wanted to highlight in terms of research that is going on with doctors and investigators here at the Breast Center at Emory. Just to give you a sense of the impact of some of this research, that's being done by doctors within our community, and just to highlight some of our interests. So for instance, we actively participated in this clinical trial that was reported a couple months ago, which looked at this tumor test. When patients are diagnosed with breast cancer, we collected those samples and then did this, developed this score from those samples. These were for patients who have estrogen-driven breast cancer, which is about 2/3 or so of our patients, and had 1 to 3 nodes involved. And the name of the score is Oncotype DX. And this is a score that we knew already had some clinical importance for patients with node-negative breast cancer, but we didn't know it for patients who have 1 to 3 nodes involved. And these are patients who are at a little bit higher risk than those that do not have nodes involved, to see whether or not patients would benefit from chemotherapy or not based upon this score. So if this score came back then less than 26, which was the majority of the case of the situations, we ended up randomizing. This was an international trial to patients to receive just hormonal therapy versus chemotherapy followed by endocrine therapy. Again, the question is, can we get away with not doing chemotherapy and still have the same sort of benefits in terms of preventing recurrences that we see if we just do endocrine therapy alone? And what we saw is that for postmenopausal patients, that if the score was less than 26, you did not benefit from chemo. And what you're looking at here are just 2 curves, patients who got endocrine therapy or got chemotherapy followed by endocrine therapy. And you can see, you can't even put like a pin between these lines. There was no benefit for these patients for doing chemotherapy. But you can see for premenopausal women that there was a benefit for doing chemotherapy. And this has been important. And this has been, practice changing, in that patients who are postmenopausal who have this score don't need chemotherapy, but premenopausal patients still seem to benefit. So the take home from this trial, again, that Emory doctors had participated in and have been heavily involved in this research, was that patients who are postmenopausal and had 1 to 3 positive lymph nodes involved and have that recurrence score that's less than 26, that we could safely not give chemotherapy. And this will save tens of thousands of women the time, the expense, all the potential side effects that we can see with chemotherapy, and just do endocrine therapy alone. And this is opposed to premenopausal patients who do benefit from chemotherapy, but at least these data give us some reassurance that giving them chemotherapy would benefit them. And then the other research that I wanted just to mention before we really open this up is with a drug that Emory has also actively participated in its development. We're actually about to open another study with this drug, with other studies with this particular drug soon to open, I think, hopefully shortly thereafter. This is an interesting drug. This is what we call an antibody drug conjugate. So the way that we think about a GPS, where the GPS tells you where you should be driving, is similar to this, where this antibody is targeting the specific protein and then delivering chemotherapy directly to those cells. So the way, this essentially is the GPS for chemotherapy. So instead of just giving it through the vein and having chemotherapy potentially, go through, in effect, all cells, this has the potential to directly target cancer cells. And what we saw was that for patients with triple negative breast cancer, which is about 20 to 25% of our patients, that in that population, patients who had metastatic triple negative breast cancer, that there was a significant shrinkage of the cancer. And this led to the FDA approval. And then we've also seen, and these data were just published in the New England Journal of Medicine, our most prominent medical journal last week, that patients actually live twice as long if they get that medicine compared to standard chemotherapy. And we are, Emory participated in a study for patients with hormone receptor positive metastatic breast cancer. We're waiting for those results to be reported. We're about to open a study for that population also about giving this drug in combination with immunotherapy. And there are also some discussions about evaluating this particular drug in patients with early stage cancer to see if we can decrease the likelihood of having a recurrence. So that is just kind of a broad sense of some of the research that some of the clinical doctors do. And I just, again, wanted to highlight things that are going on within our community. And when we think about, and this is something that it commonly comes up for patients of mine, and I suspect for Dr. Meisel's patients as well, is, well, what can we do to help, right? Like, what can we do to help move the field forward for patients here in Atlanta and in the region? And some of the studies that I mentioned are studies that are being performed by the National Cancer Institute or by our industry sponsors. But there's some studies that are not funded by those sources, and those may be a little bit higher risk sort of research that we're doing, where we're evaluating new research in the lab, or how to impact and improve the sort of disparity that we see in terms of delivery of care. So, philanthropy can really help support pilot research. And I think some of the research that's of particular interest to us in terms of our priorities, I think, and I hope, really reflects our community, meaning the diversity of our community, and trying to understand even maybe some of the biologic differences in breast cancers between patients who are Black or non-Hispanic white, how to improve the outcomes in cancer delivery, but also to think about new strategies that may be coming out of the lab that we want to look at in patients, and then also potentially incorporating new blood markers that may help us identify, even for patients with early stage breast cancer, because that's a common question that we get in our clinics too, is how do we know that the treatment that I'm getting is helping? So there are some exciting new blood markers that may help us determine risk that we're very much interested in participating and evaluating. So support from the community can also help just in terms of recruiting new doctors here. I've been on faculty now for about 6 months, But then we also have two doctors who joined us in the fall, both from MD Anderson, who have interest either in disparity work or who have some interest in immunotherapy, Dr. Jones and Dr. Sachs. And then, sometimes support can help fund a place, right? So as we know, one of the exciting things that should be happening soon is the building of the tower. And the tower construction is ongoing now. But we hope that when that space opens, that this is going to be an exciting opportunity for us to expand our reach and the kind of work that we're doing. There's going to be this multidisciplinary approach at the Midtown Tower where, we're going to be even doing blood within the rooms, when the patients are being seen in the clinic, that we're doing blood in the clinic as opposed to going to a separate place to do that. So there's lots of exciting stuff that's going on at the tower, as well as other sites as well, such as Clifton, which is where Dr. Meisel and I see patients. So that is the background. As I mentioned, we are open to discussing anything and having a back and forth, and we look forward to some of the questions that you may have.
Thank you, Dr. Kalinsky. I welcome you and Jane to kick off the conversation around some of our prompted questions that we talked about. Can you talk about how you see breast cancer treatment changing in the next 5 to 10 years?
Sure, I can start and take that one. I just also want to thank everyone for being here. It's so nice to see so many familiar names on the list of participants. And we just are so grateful for everything that many of you have done to support us thus far, and particularly the Glenn family for really supporting so many of our research efforts and for making a lot of these dreams a true reality. But to get to that question, Amanda, about breast cancer treatment changing the next 5 to 10 years, I think some of the studies Kevin highlighted in the beginning really speak to what I see hopefully happening, which is number one, kind of more personalization of treatment. We really want to know, what are the right treatments for specific patients, who should be getting what, and we want to make sure that we give everyone the treatment that they need, but not too much, because we really want to maximize success and minimize side effects. We have a number of ongoing trials looking at that in other subsets of breast cancer as well, such as HER2-positive breast cancer, trying to really understand who needs more chemotherapy and more HER2-directed therapy when they are initially diagnosed with breast cancer, and who can maybe get away with a little bit less. And then similarly, as Kevin mentioned, sacituzumab, the antibody drug conjugate that we've really seen so much great success with in our metastatic triple-negative patients. And the fact that that drug is now being studied along with other agents and potentially upfront, meaning can we use that drug in patients who don't have metastatic disease to hopefully prevent people from becoming metastatic, is that a lot of drugs that have gotten their start in the stage 4 setting then get studied in the earlier stage setting, and we've seen that they've had really phenomenal success rates. And so I think some of those things too, moving some of these drugs that have been successful in a later stage up to earlier stage so that we're hopefully able to cure more women. So I think the two major themes I hope to see and kind of expect to see going forward, just based on the direction of research here and also nationally and internationally, would be more personalized treatment for our curable patients that hopefully allows for better cancer outcomes and fewer side effects, and then even more diversity of treatment options for those in stage 4 to help them continue living well with the disease.
Yeah, this is, I totally agree with Jane. One, I also would be remiss not to thank Lou Glenn and her family, who have been such incredible supporters to the center now. And, a number of the advances that we have made as an institution has been secondary to that. So I think that, as Jane had mentioned, we are evaluating a number of new GPS-like drugs, including some in the HER2-positive space, also some that are outside of HER2-positive disease that I really think could change the landscape of how we're treating our patients with metastatic disease. I also think, to me, where a lot of my excitement and personal research is increasingly focused on is this question of blood-based markers. So, one of the common questions that we get for patients with early stage breast cancer is, like I mentioned, how do we know if the treatment's working? What can we do to monitor? And so at Emory, we are opening in the next month or two, one of the, if not the first global study that will be asking the question of, if we look at these new blood markers beyond what we've heard about from other disease types, also something that's called tumor markers, there are these other blood markers that are looking at circulating tumor DNA that do seem to identify whether a patient is at risk of recurrence. But what the question has been is whether or not, if you give a new drug or change the drug that you are giving for patients with early stage cancer who have elevated circulating tumor DNA, whether you can prevent recurrence. So we are opening a study, it's called the DARE study, that's going to be starting to do surveillance on patients with stage 2 or 3 breast cancer that's estrogen driven, to see, well, what's the rate of identifying this blood marker? And 2, if we intervene, can we prevent recurrence? And there are a number of other studies that are coming down the pike, including a study that's in development with the sacituzumab govitecan, the drug that I mentioned earlier, which, is part of, in medicine, what we like to do is have a drug that sounds so incredibly complicated and impossible to say. Like that's part of what our specialty is. But regardless, we are starting to look at whether or not there's a role for that in that sort of setting as well. And I feel like that is where the field right now is heading.
That's great. One of our other questions is, as screening programs become standard, are we seeing breast cancer become more difficult to treat, and does that mean that people are living longer with breast cancer?
I would say, breast cancer screening, has been kind of at a max for a while. I would say with the pandemic, actually, we did see a period of time, I think that's sort of slowly coming to a close, where actually people were not coming in for screening, or were, potentially having symptoms or noticing lumps, but feeling kind of paralyzed by the COVID threat and not coming in. And we saw, a lot of folks coming in and getting sort of later stage diagnoses than we would have, I think, had we not been in pandemic times. And there's some research coming out of other institutions actually also kind of documenting, percentage of stage 1 versus stage 2 versus stage 3 versus stage 4 diagnoses at different time points in 2019 and 2020, showing that that was not just here, but that was something happening all over the United States. And so that's, that has been a tough thing to handle. And I think, the research certainly bears out that the earlier stage you are at your diagnosis, the better off you're likely to do. But I think with screening becoming standard, and with screening, our ability to screen people becoming more sophisticated over time, such as with 3D mammography, really having a better understanding over who needs breast MRI versus who can get away without it, we're able to catch a lot of cancers at early stages. And that has actually made cancer easier to treat, by and large. And then, of course, more of those women are getting cured, which is fantastic. And then as far as living longer with cancer, I think, kind of a separate but related question. And I would say overall, we are definitely seeing that people are living longer with cancer, in large part to sort of advances that we've seen in how we can treat cancer, even in the stage 4 setting. Some estrogen positive stage 4 cancers really at this point, thanks to some of the drugs that have been developed, including from research here at Emory, it has become almost like a chronic disease for many patients. And we get to know these patients very well over many years, and they do extremely well. And so I think, some of the focus of research going forward, even more now than ever, needs to start to be about, not just the drugs, but also the side effects. How do we really make sure that we are optimizing people's quality of life while they're being treated for cancer? Because particularly in the later stages of cancer, people can live well for a long time.
Yeah, I agree. I think what the pandemic has shown us, because as Jane had mentioned, their data now out of the US, as well as some of our European colleagues, such as Italy, which was hit so hard by COVID, that there's been a delay with screening, and that has resulted in higher stage cancers at the time of diagnosis. So it only reiterates the importance of breast screening. The other thing I just want to mention is that it's not uncommon in my clinic as well for patients just to say, man, can't you guys do something better than mammography? Is there something that is, maybe not, that's less uncomfortable, that has a better detection rate? Some of the research that I did at Columbia before coming down was looking at some new systems, we evaluated the system that's called optical tomography, which was essentially just looking at light and seeing whether or not it could help determine who was responding to getting chemotherapy before their surgery or not. And we had some nice results. And I've had some initial communications with some colleagues at Georgia Tech about evaluating these sorts of systems. And, when we think about, sort of like high risk research that can be done like within our community, that's the sort of thing where, looking at a pilot study with that sort of system where patients don't have to get injections or compression of their breast and things like that, is something that I think would not only be patient friendly, but the question is whether this could be better than some of the systems like mammography or breast MRI that we have available now.
Yeah, I think we're also very lucky here to have things like Georgia Tech and the Rollins School of Public Health, and just so many collaborators right in one space. And it's just nice to have the opportunity to work with them on many different things, but something like that would be fantastic.
So speaking of living longer with breast cancer, how is Winship helping breast cancer survivors with the long-term effects of chemo and radiation?
I'm happy to start.
Yeah, you can start with this one, and I'll piggyback after you.
Yeah, I mean, I think that part of our goal is to not just have new research that is looking at new drugs and how to improve outcomes. That's obviously important, but it's also extremely important that we figure out ways for patients to live better, right? Not just longer, but to live better. So, we've also had conversations within the group of new research that we could do. Again, these kind of pilot studies that would be looking at new ways for us to prevent neuropathy, which is tingling and numbness in the hands and the feet, which is common from one of the chemotherapies that we give. So we've had some conversations with some of our pain doctors about ways that we could think about testing that. We've also had conversations about, for patients who take hormone pills, one of the side effects from one of the common hormone pills that we give can be pain and discomfort in the joints, which is called arthralgia. So we've had some conversations, even with some of our, as Jane had mentioned, our colleagues at Rollins, just to see if maybe we can develop apps, right, that we can better communicate with patients about whether they're having those symptoms and how can we best mitigate those symptoms that they're experiencing. And then, there are other sorts of opportunities, including integration with spiritual health and nutrition and integrative services, things like that, rehabilitation, acupuncture. So I think that there are a number of things that are hopefully going to come down the pike, and there are a number of opportunities for us to further evaluate that to improve the quality of life of our patients.
Absolutely. I would agree with all of that. And then I would add, we have a wonderful program called Revital, which is a new cancer rehab program. And they are kind of like the umbrella organization for a lot of our lymphedema therapy now. They also have massage, acupuncture, as Kevin mentioned, and a lot of services that are really helping our patients kind of work through some of the day-to-day, kind of residual side effects of surgery and chemotherapy and ongoing side effects with endocrine therapy. And I think one of the things I've enjoyed, I've now been at Emory 6 years, which is hard to believe, but it's just what a wonderful community of physicians and providers it is. And that, not just in research, but also in clinical care, it's, we have so many specialists and so many different things that kind of surround breast cancer. And I always say to patients and also to my team, it really is such a team-based effort because, having patients who, can go see a neurologist that specializes in, neuropathy and side effects of cancer medicine. We have gynecologists who specialize in menopause and have been really helpful with our patients who are battling, things like vaginal dryness and hot flushes and that really impact quality of life, but, that people are sometimes afraid to talk about. And I think mental health is also a really important aspect, and having a psychiatrist on staff who deals primarily with cancer patients has been a great resource, and really opening up to sort of talk more about therapy and other mental health interventions. Particularly during COVID, I think this has been just a hard time for so many, and being able to integrate that into the care we provide for people has been key. So I think that's, just one thing I've really enjoyed about being at such a wonderful multidisciplinary institution where we're not just focusing on the cancer, but all these sort of issues that surround the cancer and integrate with the cancer, to be able to really meet patients where they are and hopefully give them the services that they need.
Dr. Kalinsky, as the leader of the Glenn Family Breast Center, talk to us about how Winship is advancing public health initiatives in minority populations, and how is Winship helping to diversify breast cancer clinical trials, and how Emory's and Winship are leading the way in that area.
Yeah, no, absolutely. I'm gonna have, I think it would be helpful for Jane to also just talk about some of the research that she's been doing with J-Screen and things like that, because that's applicable to that question. But I think that this is one of the things that I had mentioned is that we want to reflect the community. And there's been some research that's come out of Rollins that honestly stunned me a bit, just in terms of some of the outcomes that we have within Georgia, where patients, how they do is dependent upon their zip code. And then also in some of our counties here in Georgia, patients, so nationally, we see that patients are more likely to pass from other cancers, such as lung cancer, more than breast cancer. But in some communities, we're seeing that Black patients are more likely to die from breast cancer than any other cancer. And that just has fully stuck with me. So I think that, there are a number of doctors that we have within Rollins, like Lauren McCullough, others who are interested in, looking at this disparity and to try to improve upon this and try to improve upon the clinical care for our patients. And then we have doctors as well, like I'd mentioned, Jade Jones, who's one of our junior doctors who just joined us from MD Anderson. She just got some support to look at differences within the Emory system, like for instance, Grady versus non-Grady hospitals, just looking at the rate of genetic testing and genomic testing, meaning looking at the risk hereditary wise of developing cancer, and then also looking at the tumor itself and looking at genomics and things like that, and to look at how we as providers are sending those tests and whether we are not doing so in a uniform way across race and ethnicity. So those are some of the research that we're undertaking now, but there's definitely room for us to continue to evaluate how to best approach disparities, not just in terms of the disparity within the tumor, differences of biology between races, but also to understand differences and why those are and how we can change the sort of differences in cancer care delivery.
Yeah, no, I think it's such an important issue. And I think Emory is really poised because of our patient population to make a huge impact in some of these problems, that really exist nationwide. I think, one of the challenges with a lot of the big studies that are done nationally and internationally are that African-American patients are historically underrepresented. So in a lot of the big clinical trials, like for example, RxPonder, which Kevin presented earlier on today, the percentages of Black patients in these trials is really very, very low. So we're working hard at Emory to try to understand those reasons and also try to help see if we can sort of narrow the gap in those disparities. We had a study that we did here recently published with the ethics group, actually, looking at clinical trial enrollment among Black patients and white patients and trying to understand better what some of the hesitancies were that people had about enrolling in a clinical trial. What were some of the things that they thought about? I think a lot of times both Black and white patients can have the misconception that clinical trial enrollment means they're at the end of the road or there are no other options, or that the doctors are experimenting, lots of things that, we have to work to overcome. And then there are also, differences in tumor biology that because we have such a large, wonderful Black patient population here, we have the ability to study, looking at are there genomic differences in their tumors, for example, between Black and non-Hispanic white patients that might make responses to chemotherapy different, really trying to tease out some of those differences in biology so that we can maybe target them better with more personalized treatment options. And then Kevin had mentioned the work that I've been doing with JScreen, and I just thought I would mention that briefly, because it also kind of ties in with some of the work that Dr. Jones, our new colleague, is doing with genetic testing. So JScreen is an organization that actually is affiliated with Emory and does a lot of carrier screening for Jewish patients looking to have children. So unrelated to cancer at first, really looking at things like Tay-Sachs and other genetically mediated conditions that are more common in the Ashkenazi Jewish population. And then recently JScreen decided, there are genes like BRCA1 and BRCA2 that are also more prevalent in Ashkenazi Jews, and it might be a good idea to see if they can sort of get into the cancer screening as well. So we did a pilot study here, kind of completed during COVID, actually, here in the Atlanta area, looking at patients who had at least a quarter Ashkenazi Jewish background and did not have cancer or a family history of cancer in a first-degree relative, looking at genetic testing, because those patients often can't get genetic testing done through their insurance because they don't qualify. But would they like a program where they could do this testing for free? And how would it go doing the counseling virtually? How would they feel if a mutation was found? Looking really at all these quality of life kinds of things and the experience of the testing as well. The pilot study enrolled quickly. It went well, and the feedback was extremely helpful that we got from the participants. And JScreen has actually opened this up now nationwide so that this testing can be done not just for Jewish patients, but also for African-American patients, Hispanic populations, anyone. And one of the things that we found actually in some of our studies here at Emory is that in ovarian cancer patients who were treated here, This is data that will be presented at our big meeting at ASCO, which is the American Society of Clinical Oncology in June, that ovarian cancer patients here who are supposed to get BRCA1 and 2 testing, because those patients often are harbingers of those mutations as well, that oftentimes those patients are not referred for genetic testing and genetic counseling, and that Black patients were referred less often than white patients. But what we found was that when Black patients are tested, they actually have higher rates of BRCA1 and BRCA2 mutations than white patients. And so this definitely was food for thought and dovetails nicely with some of the research being done in breast cancer patients at other institutions, kind of highlighting the need to, enhance our knowledge and education on genetic testing for Black patients as well as white patients. So a lot of these things are initiatives we hope to carry forward here at Emory over the coming years and decades.
Thank you. Winship is really poised to ask and answer some of the most pressing research questions about breast cancer. So, if money were not an issue, what research questions would you like to ask?
So I can start with that. So, I think that, and we've kind of talked about some of those research opportunities. And I think that, to me, if we were to put them into different baskets, I think that there's the symptom management basket, to what kind of studies can we do to best see whether or not we can not only improve the symptoms that patients are having, but also how can we ensure that the symptoms are better to the point where patients are adhering to their medicine more. Because even some of the data that we have, or for patients who are taking endocrine therapy, for instance, after about 2 years or so, about 50% of patients stop taking their endocrine therapy for various reasons. So there's lots of room for us to do better. I think there's also the laboratory science component, right? So with our lab scientists, they are interested and mindful of, well, how can we translate that work from the bench to the bedside and then back? And we have a number of collaborators who are interested in collecting tumor tissue and or blood so that they can do evaluations that then lend themselves to new discoveries. And so there are a number of opportunities with lab scientists that we have now, as well as also recruitment opportunities that we have to really help with that. And then the disparity work that we had talked about. I think that there's just a real opportunity with Rollins and then also other epidemiology-based investigators in the state of Georgia so that we can better improve the outcomes of patients within the state.
One thing I would add to that, I think, as we think about disparities, I think one of the things we think about here is, the diversity of our community. We have the Clifton campus, which is where our, very robust and large phase 1 drug treatment program is. And then also where a lot of our clinical research takes place in the phase 2 and phase 3 trials that we run primarily through the breast center. But there are also all of these wonderful Emory community sites. We've got Johns Creek, we've got St. Joseph's, we've got Emory Midtown, and then Grady, of course, which is affiliated with Emory and has a very diverse and often underserved population. And sometimes it can be harder to open some of our more complex clinical trials at those other facilities. And I was trained at Sloan Kettering, so that was my institution prior to coming here, and they had the same issue, really, that everything was sort of centered at the mothership, and then it was harder to open some of those trials at the New Jersey and Long Island sites. So lots of parallels that I see, but I think if money were a non-issue, I would also really just build and I think we're working towards this anyway, but really try as much as we can to make all of our sites clinical trial infrastructure as robust as it is here. And for patients who are particularly underserved and maybe don't have as many resources like at Grady, be able to offer potentially initiatives to help make clinical trial enrollment and participation easier to sort of further that diversity goal.
Yeah. I have some points that I want to add on to what Jane.
Yeah.
So, I think that, one of the questions comes up of like, well, how do funds for research, like, where do they go to? And then sometimes they go to staff, making sure that we have the coordinators or the nurses available to do the sorts of research that we want to do. And we are growing that team at Clifton. And we were growing them at other non-Clifton sites as well. But it would be great if we got to a point where, as Jane said, we could open up some of the complex studies. Like, for instance, we participate in a study called the I-SPY study, which is a study where patients get novel and new therapies with chemotherapy before they go to surgery. And this is a national study where Emory is one of maybe like 16 sites across the US that participates in this. We're the only site in Georgia. And right now we're only open at Clifton. And it would be great if we had the sort of support to be able to open this across all of the Emory sites. Like that would be a terrific goal for us to try to achieve. Oh, and the other thing I wanted to say, I knew there was something else. So the other thing I just wanted to say, and it's a little bit off topic, but I've been thinking about this because this is something that's going on this week, is that one of the things that's happening at Clifton in Midtown is the development of this urgent cancer care center, which I think for our patients is something that's going to really make this unique of Emory compared to some of the other local and regional sites where our patients with cancer, instead of us just saying, oh, you're sick, like just go to the emergency room, there's this urgent care center where we will be able to send patients to be evaluated with, for instance, nurse practitioners and other healthcare practitioners with whom we would work. So, I think that this is something that's going to open for our patients, hopefully early next year. But I think that this is something that's going to be great at Midtown. This is something that's going to be available at Clifton. It would be nice if it was across all sites. But this is something that from the clinical perspective is something that's going to be really nice for us to offer our patients with breast cancer.
You talked about this, or you touched on this earlier, but here's a question from our chat. Can you talk a little bit more about immunotherapy and how that's playing a role in new treatments?
Sure. Kevin, do you want to take that one? You're welcome to. I can piggyback off of you.
Sure. So, right now, immunotherapy is just approved for patients with metastatic triple negative breast cancer. And just to make sure we're also on the same page, what immunotherapy is giving this treatment intravenously that tells your body to attack the cancer. So like Jimmy Carter, how he's been treated for his melanoma is with immunotherapy. So we're waiting to see if this can be approved in patients with early stage breast cancer. So patients with newly diagnosed curable triple negative breast cancer. And hopefully we'll see that this will be rediscussed with the FDA in the fall. As there's maturity of the data that have currently been made available. But I think one of the things that we're interested in are two things. One is whether there could be a role for immunotherapy outside of triple negative breast cancer. And we have some clinicians as well as lab scientists who are specifically interested in some of these less stimulatory cancers such as estrogen-driven breast cancer about whether or not there's a benefit for those patients. And the other thing that we're interested in, and we've had some proposals for, is to look at differences of immunotherapy response based upon race. For instance, our patients with triple negative breast cancer that's metastatic, are the side effects or the responses difference between our Black and non-Hispanic white patients. So we are interested in this approach in those areas. And then actually the only other thing I just want to say is that in multiple myeloma and heme malignancies, so cancers within the blood, there's a new type of immune therapy called CAR T cells, which has revolutionized how we treat those cancers. They haven't quite yet been as effective in patients with solid tumors like breast cancer. And we've had some conversations with some other new lab scientist recruits about developing CAR T cells for patients with breast cancer. And I think that, when we talk about, what sort of support we could have like within the community and the kinds of recruitment of scientists and things like that, like that's an example of a recent recruit, which could then lead to clinical trials for an area of unmet need.
Absolutely. I think you summarized that really well. I was just going to say one of the other things, with all the success that we've seen in the metastatic triple negative setting with immunotherapy, one of the questions that arises, of course, is how do we bring immunotherapy up front in a safe way that helps more people, get cured of their breast cancer and do well without, making side effects too prominent. And that's one of the things that's being looked at, as Kevin said, by the FDA as in terms of where these drugs should be approved in the upfront setting. And then, in what other disease types can we see this work? So with sacituzumab, which is that antibody drug conjugate, GPS-like drug that Kevin had mentioned before, it's done so well for our metastatic triple negative patients. And that was then one of the studies that we did at Emory that's now fully accrued was looking at that drug in patients with estrogen positive metastatic breast cancer that has stopped responding to endocrine therapy. So those patients who have a little bit more endocrine resistant disease, might they kind of respond to these triple negative based treatments? And where I'm going with that is we actually also have a study open here looking at immunotherapy in that estrogen positive breast cancer patient population. This was actually a study that was initiated by an investigator at Dana-Farber in the Harvard system. And then we opened with them kind of as a partner site and as the only site here in Georgia. And it's looking at second line treatment for estrogen positive stage 4 breast cancer, seeing whether the addition of immunotherapy to standard endocrine therapy can be helpful. And we've actually been a very high enroller in this study and look forward to seeing what that shows and whether that ends up changing things for patients. So lots of places for this to go, I think. And then one thing I also wanted to mention, because I am also very excited just from a patient care standpoint about this urgent care center and what that will mean for our patients. A lot of our patients, particularly who are getting chemotherapy or even getting immunotherapy, end up coming in and needing, for example, a blood transfusion or IV fluids. And so things like that, for them to be able to just come to an urgent care center and be evaluated by an oncology practitioner, as opposed to having to wait in the emergency room, is really going to change quality of life. And that's also an example of something that was funded by philanthropy and is going to make a huge difference right away in terms of patient care and the quality of care we provide at Winship. So just a huge thank you to those who helped make that a reality. And as Kevin said, it would be amazing if we can do that in years to come at some of our other community centers.
Yeah, just also kind of as a little bit of a point of reference. So before coming down, I was at Columbia in New York City for the last 12 years or so. And we had an urgent care center, which made a difference for our patients, but it was only 2 beds. Here at Clifton, we're anticipating that it's going to be at least a dozen beds, right? So it's really going to be something that will really make the patient experience significantly better here. I think all around.
Absolutely.
One other question we had is, and Dr. Kalinsky, you touched on this about new recruits. You've talked about some of the exciting research that they're doing. What are some, if money were not an issue here in that area, what are some of the gaps in talent that you'd like to fill at the Glenn Family Breast Center?
Yeah, I think that, some of the recruits that we've had on the clinical side have been great addition. I mentioned the 2 individuals from MD Anderson that just joined, one who's interested in disparity work, the other who's interested in immunotherapy and also is doing a study with repurposing drugs. And what I mean by that is evaluating, hopefully we'll be opening soon a study with giving we have, for instance, we know that we give statins for patients with cholesterol all the time, but there's some suggestion that maybe there is some anti-cancer effects. So that's a study that we're going to be evaluating here to see if there's a role for that, because that could also have, if that's the case, we could study this on a national level and could have some global impacts as well. But I think that where we're going as a center, I think that we have some terrific scientists who are focused on developing new research that we can then bring over into clinical trials for our patients. But I think that, this is something that we're hoping to continue to grow, including recruiting some, more seasoned scientists, because, I think that what we're seeing within the breast group is that we're an increasing mass. We're an increasing mass of individuals, both in medical oncology and other clinical disciplines in Rollins and laboratory science. And I think that, continuing to build that group will only make us get to where we're hoping to go sooner.
Any other final thoughts from you, Dr. Kalinsky or Dr. Meisel?
I think like big picture wise, there's a breadth of research that's going on here. And I think we highlighted some of that, whether it's new treatments or whether it's symptom management or whether it's disparity or whether it's lab work, there's lots that is going on. And we have a great group of clinicians and scientists that are looking at this. I think the other point that, I hope that we have made is just also the work that we're doing on the clinical side, just to, help improve the lives of our patients and to make their life easier, and for them to have more time that they are spending with practitioners, and then also not as much time that's being wasted doing other things. So I think that that's where things are going within the group, and that's the goal for next year, but also for the next couple of years as well.
I agree. I would say, I think everything that we are doing to try to advance patient care in very specific and definitive ways, and also just so many amazing opportunities in the research world has been great. One of the things I've enjoyed really working with Amanda and also with Emily to do is to help folks who want to give some amount, really think about what they're interested in giving towards, and then kind of helping connect donors with projects that really speak to what their interests are. And so I think, there's so many options and so many opportunities, and we're so grateful for the gifts we've received that have allowed us to take so many projects and ideas, to the next level.
And I just want to reiterate one thing that Jane just said. I think this is a community, right? Like we are doing work to move forward this for people in our community. And as Jane also had mentioned, if somebody's interested in a specific thing, then it's meaningful to then hook that person up with somebody who's doing research in that area, so that we feel like we're moving that part of the field forward.
Yeah, no, I think it really is, at best, a sort of a dialogue between all of us, because everyone who is part of the research program, people who help fund it, people who help come up with ideas, patients and patient family members who give us feedback about what they're experiencing so we can do better research to improve the patient experience. All of that is part and parcel of what we're passionate about. And I know Kevin and I would be happy to take questions if people think of things offline. If you have things, we would love to be in touch with you.
Thank you so much, Dr. Kalinsky and Dr. Meisel. Guests you'll see here, my colleague Emily Williamson. If you have any questions about the content that you heard today, or any want to hear more opportunities about philanthropy, you can contact Emily here. Her email address and phone number are listed. I want to thank everybody. There was a question in the chat about our breast cancer support groups. I'll be sure to email that information to the group along with the recording. And there's also a question about the fashion show. Many of you participated in our Fashion a Cure program, Fashion a Cure campaign this year. We were able to raise over $100,000 for the Glenn Family Breast Center, and we'll be working with Dr. Kalinsky to identify the right project that will help advance their research in that department. So with that, I want to thank you again all for attending today. Thank you also again to Dr. Kalinsky and Dr. Meisel. We hope you enjoyed the program, and we hope you have a wonderful afternoon. Take care.